So after discussing all the various etiologies, pathogenesis, the clinical features, and the lab diagnosis, now let's look at what are the various treatment modalities that we have for the primary myelofibrosis. Since it is a genetic disorder related to the mutations or the chromosomal problems, we don't have a specific cure. The curative management is the hematopoietic stem cell transplantation. But as we know that very few patients, they find a donor, a suitable donor, or they uh, basically are on the merit for this hematopoietic stem cell transplantation. So all what we want to do is the symptomatic management. We try to make the patient life as much better and the symptom free as we can. Based on these various risk factors and the various symptomatology, we have developed certain scoring systems. So if we have a patient who is diagnosed with myelofibrosis, there are a few scoring systems, the details of which you don't need to know. The major ones are the abbreviated as the DIPSS or the DIPPS plus scores. So we have various types of risk factors in these patients, the various types of presentations depending on their age. And then we calculate the various risk factors, we add up the score, and depending on that score, we stratify the patients in the various risk factor categories. If we have a low score and the patient is in a low risk category and the patient is asymptomatic, there are no clinical symptomatology, then what do we have to do? We have to just observe the patient, and then the patient can have regular follow-ups over a period of time, and we have to see that if the patient develops any of the symptoms or the patient's risk factors increases, then we have to intervene. But for the time being, a newly diagnosed case of myelofibrosis in a low risk category, specifically if he's asymptomatic, you just have to observe that patient. If the patient is an intermediate risk patient and they have all the signs and symptoms of myelofibrosis, then depending on the predominant symptomatology, we cater the various types of treatment modalities. For example, if the anemia is the major presenting complaint and anemia is the major troublesome thing for the patient, then in those patients, we have a lot of treatment options. We can either try various immunomodulators like the steroids or the androgens or the immunomodulator drugs. Certain new investigational drugs targeting the JAK2 receptors like the ruxolitinib, they have also been tried. Certain types of immunomodulators like the interferon therapy has also been tried. And these have shown mixed results in various patients. We have also seen a combination of prednisone with other types of immunomodulators. This has helped a few patients, but since these drugs have their own problems, certain cytotoxic disorders on their own can cause certain problems. So the risk-benefit ratio is basically weighed, and then we look at what suits the specific patient. If even after trying various types of medicines, that anemia doesn't go away or it is troublesome for the patients, then the final option which we are left with is the transfusion therapy. So we basically transfuse the patient and that patient develops the transfusion-dependent anemia. There is periodic transfusion depending on the HP levels of the patient. And with transfusion, you have to look at the other important things. You have to look at the certain types of bloodborne infections like the CMV. You have to look at the patients developing iron overload, just like the patients with thalassemia. When they're transfused very frequently, they can develop iron overload. And you might have to give certain types of iron chelating drugs like deferoxamine to these patients to counter this iron overload. So this is how we basically manage the anemia of this patient. If we have a spleen enlargement and the patient develops spleen-related symptoms like the basically increased satiety or organomegaly, leading to portal hypertension or ascites, then the major drugs which we have, the first-line therapy is a newer drug, which is a JAK2 inhibitor, comes by the name of ruxolitinib. It has shown very good results, specifically in controlling the spleen size or the spleen-related issues. That has been found to be effective in a large number of patients. If it is not working for the patient, then we go on to the second-line therapy, which has the cytotoxic drugs like the hydroxyurea, certain types of immunomodulators, certain new investigational drugs. We can also, these drugs will on most part cover the spleen-related symptoms and will help ameliorate the symptoms. But in certain patients, when these drugs are not helpful, we can try out splenic irradiation. Radiation therapy can lead to the splenic shrinkage or decrease in the spleen size, and then that can help us with the symptomatology of basically the pressure symptoms of spleen will be ameliorated, and that is very helpful in a large number of patients. Specifically, this is helpful for very old and frail patients which are not able to undergo the splenectomy. Splenectomy can be done in younger patients presenting early on, and in those patients in which the drugs haven't controlled the disease. So we have to remove the spleen eventually to make the patient's life better. But removing a spleen has its own sequelae. We have to immunize the patient against a large number of infections, specifically the pneumococcal vaccination. Pneumovax is very frequently given for these patients. And certain other types of things which we also have to look for. The patient is basically immunocompromised when you have replaced the spleen, and you have to manage the other conditions very effectively in these patients. These are the various options we have to control the spleen-related issues. If the patient develops other cytopenias, then we can basically provide supportive therapy. Some new investigational drugs like the ruxolitinib have been found to be effective in ameliorating the symptoms, or certain types of steroids like prednisone. They can also be tried in combination with immunomodulators or the cytotoxic drugs. If the patient is high risk or the intermediate 2, and we have an appropriate allogenic hematopoietic stem cell transplantation candidate, either the patient is young or the patient has a very perfectly matching donor, then we can proceed on with the hematopoietic stem cell transplantation. And this is the only curative therapy which we have. And the patient will get better, but as with any other transplantation, there can be certain rare problems. There can be certain immunological problems. The patient might have to take immunomodulators for their whole life, and that is why this is reserved only for the patients which are very strong candidates and which can't either they are very young patients or they have a very suitable donor for the allogenic transplantation. And this is the only curative therapy we have. The major treatment modalities are tailored on managing the symptomatology, just like the other types of myeloproliferative disorders or the other types of various leukemic malignancies that we have in these patients. So with that, we complete our discussion on primary myelofibrosis. It is one of the myeloproliferative disorders, just like the essential thrombocythemia and the polycythemia vera, which we discussed in the other lectures. I hope with this lecture you are able to learn something new, and after this lecture you'll have a very good understanding of the various myeloproliferative disorders. What are the various differentiating features of the disease? What are the symptoms which are common to all the things? What are certain classical symptoms like the interchangeability of these disorders? And when you have a patient in real life, or if you have a question in the exams, you are able to diagnose that patient and you are able to work it up properly. I'll see you in another lecture. Thank you.